The University of Michigan Division of Gastroenterology and the Inflammatory Bowel Disease Program host the IBD Visiting Professor Lecture Series in Ann Arbor, Michigan. This series presents the latest in clinical research and basic science from IBD experts from around the world.
Thank you, Peter. Thanks everybody for coming this morning. Thanks for having me. So what I thought I would do is give you...
May I have your attention, please? Maintenance is working on the fire alarm system.
Okay.
May I have your attention, please? Maintenance is working.
So I'll give you a few highlights of some of the work we've done in Olmsted County related to the natural history of IBD. Talk about, what endpoint should we be following? Do we ever have any hope to alter the natural history? And then try to work in another interest of mine, which has been a fruitful collaboration with our GI radiologists and the importance of accurate not only diagnosis but disease activity assessment and how that natural history aspect and activity assessment interact. So a lot of what I'll be talking about today is based on a population of IBD patients from Olmsted County, Minnesota. Olmsted County is in the deep south of Minnesota, down in the southeast corner. We're about 40 miles from Wisconsin, 40 miles from Iowa, about 75 miles from the Twin Cities. And the unique thing about Olmsted County is that there really are only two major healthcare providers in the county. There's one small solo family practice, but since the 1960s, these two medical centers with their respective hospitals and this other family practice have had an NIH-sponsored linked database. So it's basically a diagnostic index. So every time a patient is seen in the emergency room, seen in a nursing home, has an autopsy, has an endoscopy report, has a biopsy, all those diagnoses are reviewed by a team of sort of professional coders, and these are entered into a diagnostic index. So you can actually do true population-based studies. You don't have to rely on a hospital discharge summary. So an outpatient visit generates an episode of care with billing codes, which are reviewed by these experts and entered into this database. So it's one of the few places in North America where you can do true population-based studies and that aren't just relying on a billing code or administrative code. You actually have access to the complete medical records of all these patients so that you can actually validate the fact that they have a particular billing code. And over the years, I have on this slide that over 1,600 papers have been written on Olmsted County. It's actually over 2,000 at this point. So in 2000, the county was 89% non-Hispanic white. That's down to about 85% now. And you can see that a high percentage of residents are employed in the healthcare field, and more than the average have gone to college. But other than those two facts, it's largely similar socioeconomically to the US white population. So it's not perfect, but it's the only place in the country where you can really do such a study. And I'm going to stop for a second and let you read this sort of quote letter to the editor written by Tom Ullman. He was concerned that the use of the term urban center was a perversion of the term requiring immediate explanation. Although a Gap and an Applebee's can be found in the sprawl of Rochester, there are an insufficient number of slums, crack houses, art museums, and AIDS patients to term Rochester urban. Those of us working in true urban centers demand explanation and apology. This didn't actually appear in GUT, but this was a fake letter. It was unofficial Mount Sinai letterhead that Tom had sent to us. But it brings up an important point. Oftentimes, Olmsted County studies get criticized because it doesn't represent a true slice of, multiracial and multi-ethnic America, but I think it still is valid to do such studies. And in the interest of time, I didn't show examples of how we've been sort of validated externally, but if you look at our incidence and prevalence estimates in Olmsted County, they're remarkably similar to estimates using other databases around the country. So I think it's still a reasonable population to study. So I want to shift a little bit and talk about the natural history of ulcerative colitis. This is a classic cohort of patients from Copenhagen County, which is actually suburban Copenhagen in Denmark. And there were a series of studies both in UC and Crohn's back in the early 90s and late 80s describing this population. But the point here I want to make is the green bars represent patients who underwent colectomy over time. The yellow bars represent patients with active disease, and then the blue bars represent patients in remission. And you can see that that initial first year after diagnosis, you have the highest percentage of patients that have active disease, and then that declines with time. More patients in remission, and then of course there's this cumulative risk of colectomy. It's important to note that these aren't the same patients that are in remission. Your people are continuously going in and out of remission, and that's just the nature of the disease. It's a waxing and waning disease. So the question becomes, if you're going to try to measure natural history endpoints, which ones do you measure? Well, hospitalization seems like a reasonable endpoint. This is a study showing that the cumulative risk of hospitalization for ulcerative colitis patients was 50% at 20 years after diagnosis. And then if you could go regress back to the baseline risk factors to see what factors were predictive of or associated with hospitalization. And what we found in our study was that early use of corticosteroids, early need for hospitalization, meaning the first 90 days after diagnosis, and extensive ulcerative colitis were all significant predictors of hospitalization. And in the case of early hospitalization, we're talking about subsequent hospitalization. So you can start, we'll get back to this point later, but you can start thinking about, okay, what are the markers of more active disease, or what are the markers of bad behavior, if you will, or adverse prognosis in patients with ulcerative colitis. The problem with hospitalization is that that's a moving target, and if you just look at secular trends in hospitalization over time, they've gone way down compared to the beginning of this study period, which was 1970, so maybe not the best marker. How about surgery as an endpoint? That seems like a harder endpoint than hospitalization. Maybe there won't be as much practice variation around surgery. So in our studies, we found that the cumulative risk of surgery in UC is 27.5% at 25 years after diagnosis. So in my mind, if you need to have a number when patients ask you, newly diagnosed, what's my risk of getting a colectomy? I tell them it's going to be somewhere around 25 or 30%. So that's the number you want to have in your mind when you're counseling your patients. And again, you can regress back and look at what are the factors that are predictive of surgery. And one of the most remarkable things that we've found, and other people have confirmed this, is that being a male really increases your risk of colectomy. And this has been seen in Bernstein's data from Manitoba. It's been seen in other cohorts. But look at that, you're twice as likely to require surgery if you're a male than if you're a female with ulcerative colitis. The only explanation I have is that men are not very compliant with medications. Maybe they're having more flares, I don't know. Maybe they're too focused on making a YouTube video modeled off of Jackass. I don't know what it is, but it's just males are just more likely to have a flare and require colectomy. The other concerning thing in our data, and this hasn't been seen in other cohorts, is that we found that more recently diagnosed patients were actually more likely at any given point in time to require surgery than patients who had been diagnosed in the 1970s. And this kind of goes against at least two other population-based cohorts where we have data. Bernstein's data in Manitoba shows that there was a secular decline in colectomy rates over time. You'd think that that kind of makes sense, better medications, better therapy. And that's been seen in a European cohort as well. I don't have any good explanation. We've gone back to these charts, and actually I've had a lot of trouble getting this paper accepted because I don't think the reviewers believe the data. They don't understand why the surgery rates are actually going up and not down. I've gone back that C diffs are negative. There's no apparent explanation. Was it that we're just becoming more comfortable with surgery as an option because we're lucky enough to work, live in the same county with an excellent group of colorectal surgeons? Perhaps. but this is a bit of a troubling statistic, and I don't have a great explanation as to why that's happened. Is it a change in the diet, or is it a change in the way we process food? I don't have a great explanation for it. Other studies have shown that early use of corticosteroids is a risk factor for colectomy, and you can see here at the bottom a variety of different experiences, and this is the risk ratio or the odds ratio, and you can see that in multiple studies, early need for steroids will predict colectomy. And again, that doesn't imply that steroids are causing colectomy, but it's just that that's a marker of severity for your patient. So again, start thinking about these risk factors when we want to risk stratify patients later on in terms of who needs top-down or who needs bottom-up therapy. So let's shift a little bit to Crohn's disease. Crohn's disease, again, is characterized by waxing and waning course, similar to ulcerative colitis. Your first year after diagnosis in this Copenhagen County cohort, you have the highest likelihood of high activity, and then over time you sort of equilibrate, and you have the same percentage of patients in remission, in low activity and high activity, but again, the same patients are coming in and out of these different disease states, so it's not that you're stable over time. It's characterized by a waxing and waning course. And again, for counseling patients, what I like to tell them when they ask me, like, how severe is my Crohn's going to be? I say, we don't know. I tell them, you have a 25% chance of being sort of a continuously active or chronic active patient. You have a 20% chance of, after your initial flare, going into a prolonged flare. But most likely, you're going to be here in the middle, and you're going to have a waxing and waning course, meaning you're going to have some good years, and you're going to have some bad years, and you hope that the good years outweigh the bad years. And if we find the right medication or combination of medications, we can hopefully get you in remission. Surgery risk as an endpoint in Crohn's disease. Again, classic landmark paper by Pia Munkholm and colleagues from Copenhagen, and I think this is the number that most people use. They'll say, you have Crohn's disease, you have an 80% chance of a bowel resection after 20 years, and in fact, there are many people at 15 years who have had two or three or more surgeries. Now in Olmsted County, our experience is a little bit less severe or less stark than that. When we've looked at this at 30 years from diagnosis, there was roughly a 60% cumulative risk of a bowel resection. And if you had required one resection and started the clock over from that time forward, the risk of a second resection was again 60%, meaning that 36% of patients have had two resections, and then if you start the clock over, again, it's about a 60% risk after 30 years. So you get a progressively smaller tail, if you will. But when we looked at the median number of surgeries in our cohort, the average number was 1, and this was over like 14 years of median follow-up. But we had one patient, we had 0 for 40% of patients, and then we had one patient with 29 surgeries. So there's that long tail, and we don't know what is causing that tail, what causes some patients to be more severe. We don't have a good handle on those. So this is a paper that's under submission right now. This is our Crohn's disease experience with surgery, and it shows you some of the cumulative curves that I just showed you. But then when we regress back and look at what are the baseline factors or the factors that you could identify in the first 90 days that predict time to surgery, and being a male, small bowel relative to colon, ileocolonic relative to colon, upper gut relative to colon are all significant risk factors. In fact, these are the biggest risk factors. So it's your location of disease that predicts your risk of surgery more so than anything else. And if you think about it, ASCA tracks with small bowel, so this kind of makes sense. You know, ASCA has been shown to be a predictor, and ASCA tracks with small bowel locations, so that kind of fits. Current smokers were more likely than non-smokers. If at baseline you had penetrating disease, this was a risk factor. Stricturing disease was not a risk factor, and then of course early need for corticosteroids were a risk factor. So most of these make sense. I don't think we still again fully understand why males seem to require surgery more often than females. Now when we looked at cumulative surgery rates over time, we did not see a significant trend. And so this just shows you the different calendar periods of diagnosis in 5-year increments, and it's sort of all over the place. I mean, there's a little bit of a sense that the most recently diagnosed, actually no, the most recently diagnosed cohort is over here somewhere, so never mind. But there were no significant p-values among these comparisons for cumulative surgery rates. What are other ways you can look at severity of Crohn's disease? One is to try to come up with a composite definition or endpoint of what you consider severe Crohn's. So this was a French attempt to call severe Crohn's disabling Crohn's, and they used this composite endpoint of more than 2 steroid courses or steroid dependence, hospitalization, disabling symptoms for perianal disease or extraintestinal symptoms, need for immunosuppressive therapy, or an intestinal resection. So kind of it's an okay composite, I would argue with, I think this becomes a self-fulfilling prophecy if need for immunosuppressive medication is part of your definition. But in any case, it's a reasonable attempt. So they looked at this was the Saint Antoine group in Paris. They looked at over 1,100 patients, and they found that the 3 factors that independently predicted a disabling course based on those definitions over the first 5 years of disease were early need for steroids, age below 40 at diagnosis, and perianal disease at diagnosis. So one of their younger colleagues at the time came over to Rochester and looked at our Olmsted County data and tried to replicate their model in our data. And what they found was that right off the bat, 17% of patients didn't qualify because they had their surgery within the first 3 months of intestinal resection, and those patients had been excluded in the French study. And then 54% met the criteria. So when you add those two together, that 72% met the disabling criteria within the first 5 years. So most people are actually meeting the severe criteria. And then when you looked at those 3 factors, initial steroids, early age, perianal disease, they were modestly predictive. So if you had 2 or 3 of these, your predictive value of having that definition was 74%, whereas if you only had 0 or 1, you had a 48% chance. So I think that attempt to replicate their model was, it's reasonably good, but I think we can do better than that. Another way you can look at this is look at the disease behavior over time. So you have, most of us think everybody starts out with inflammatory disease, and then as time progresses, you develop intestinal complications, either fistulas or strictures or abscesses. And so this is the classic study, again, from the same group in Paris. Most patients start out inflammatory. You can see that roughly 82% start inflammatory, a small percent stricturing, a small percent penetrating, but over time, more people develop penetrating complications and stricturing complications, so that when you're 20 years out, only 15% of patients are still pure inflammatory. So if you want to intervene with medications to alter the natural history, you probably have to do it earlier on before those intestinal complications have developed. So we actually took the Montreal classification, or the Montreal modification of the Vienna classification, and applied it to our own data in Olmsted County, and we found that in the cohort diagnosed between 1970 and 2004, 81% at diagnosis were pure inflammatory, 14% were penetrating, and about 5% were stricturing. So right off the bat, 19% of patients at diagnosis already had an intestinal complication. So let's just take the segment that had the B1 or the inflammatory disease. If you follow them out over time, 30 years, there's about a 50% risk of developing an intestinal complication. So that's telling us a couple things, right? I mean, it's telling us that there's that subset of, 50% of 80 is about 40%. So 40% of patients aren't ever developing an intestinal complication. And remember, 40% of patients never require surgery. So that's one of my goals, is to go back and study that 40% and figure out what it is about that 40% that is allowing them to not progress, if you will. And can we pinpoint those patients and know that we can take sort of a leisurely bottom-up approach with those patients. But it's also telling us that there's this significant risk of progression in half of the B1 patients. So if you add those B1 patients who progress to the patients who already started off at diagnosis with a complication, the cumulative risk of a complication after 30 years is almost 60%. So when you regress back then, okay, what factors at baseline predicted intestinal complication? It's largely similar to what we talked about with surgery. Ileal disease relative to colonic disease, ileocolonic disease relative to colonic disease, upper GI involvement, and perianal fistula was borderline significant. My personal view is that the single most important factor in predicting whether your patient is going to need surgery or develop an intestinal complication is their extent of disease. So you know right off the bat, a patient with ileal disease has a high risk of progression relative to a patient with pure colonic disease. And that doesn't always fit in with some of our preconceived notions, because we tend to think about those patients with severe Crohn's colitis who need a colectomy and have an ostomy. But those are the minority of patients with colonic disease, and most patients with colonic disease keep their colons and have mild disease. So just keep that in mind when you're seeing patients. It's the patients with ileal involvement or ileocolonic disease that progress, and that's the majority of patients. So risk factors for predicting bad natural history: young age at onset, ileal or ileocolonic extent, fistulizing disease at diagnosis, early need for steroids, and ulcerative colitis, extensive disease, male gender, early steroids, early hospitalization. So just you start thinking about these factors when you see your patients. I'm not going to spend a lot of time on these data with regards to medications. You're all familiar with these studies, but just to make a few points here. So azathioprine alone probably isn't sufficient to alter the natural history. This is a classic study from Paris showing that over successive periods of time, they were using more azathioprine, such that by the end of the study, well over half of patients were on azathioprine within 5 years of diagnosis. And having said that, they didn't alter the risk of surgery. So the increasing use of azathioprine did not result in lower surgery rates in their cohort of patients. Maybe it was underpowered, I don't know. I have to say that there are at least 2 subsequent studies, one from Mayo Jacksonville and one from a population-based cohort in Western Hungary, that have shown that azathioprine can alter the natural history of disease, but I still think that probably needs to be replicated in more cohorts. What we do know from 1-year treatment trials is that infliximab and other anti-TNFs probably can alter the natural history. So this is one example from a spin-off of the ACCENT-1 study showing that patients that received episodic infliximab had a roughly 9% or so risk of resection within that study. And then patients that were either on scheduled 5 mg per kg or 10 mg per kg had a risk that was less than half of that. So at least in that 1-year cohort, you could reduce the risk of surgery. And then similarly, another endpoint would be hospitalization, and I used a different anti-TNF as an example. Adalimumab was shown in the CHARM study, which was the big maintenance trial. You could reduce the risk of hospitalization over 1 year by more than half. So the yellow is the adalimumab arm, and the white is the placebo arm. So there is a significant risk reduction in these big endpoints like hospitalization and surgery. What we don't know is if you follow those patients out 3 years or 5 years, would you still see those same differences? And we just don't have that data. And at some point, it would be nice to have that data. Another thing that we know from these treatment trials is that when you stratify by disease duration, meaning from the time of diagnosis to the time they enter the study trial, the patients with the shorter disease duration tend to do the best. And again, I used an example from one of the trials, but all of the anti-TNF drugs have similar sort of sub-analyses and show the same thing. Shorter duration of disease, higher response rate. So this is sort of circumstantial evidence that earlier disease treatment might be more beneficial. This is the step-up, top-down study, and I'm not going to go into this in detail, but the patients who received infliximab, 3 doses, then episodic, along with azathioprine versus our conventional step-up approach, the first 3 sort of data point checks at week 14, week 26, week 52, there were significant differences in the endpoint, which was steroid-free remission, no resection. But after that, the differences became non-significant, and the reason everybody thinks is because the infliximab was given episodically in this study and not as scheduled maintenance. Having said that, loss of difference over time, you could look at endpoints like endoscopic healing or mucosal healing, and you could see significant differences. The top-down group has 73% complete healing versus only 30% in the conventionally managed step-up group. Now that takes us to the SONIC trial, and again I just want to make a couple brief points about SONIC. This is the major endpoint in the entire cohort. So the patients on combination therapy had a 57% rate of steroid-free remission, and the azathioprine alone group had a 31%. So the delta on that is about 26. So that's like a number needed to treat of 4, which for an IBD study, especially one with this kind of endpoint with these kind of patients, is pretty good. And I'm going to show you, to me, this is the most important slide in the whole talk. And the point of this is that if you actually had demonstrable inflammation, meaning that on your baseline endoscopy you actually had endoscopic evidence of inflammation, your delta between the lowest arm and the highest arm goes from 26 points to 31 points. So that goes up. And then in the group that had no demonstrable inflammation on endoscopy, there is no delta. There's no difference. In other words, infliximab is not a good IBS drug. That's what it's telling us. So patients that don't have their symptoms due to active Crohn's disease don't get better with combination therapy. And that's the most important slide I'm showing you. Now you can look at it a couple different ways. You can look by CRP. CRP, as you know, is great when you initially see a patient when it's high, but it's not sensitive enough. And there are many patients out there who have normal CRPs and yet have active inflammation on endoscopy. So CRP is just one piece in the puzzle. Yes, I check it routinely on my patients, but if I see a normal CRP, that doesn't dissuade me from doing other things to see if the patient has active inflammation. So CRP, the delta here goes up, but I still think it's a major issue. And then when you combine endoscopy and CRP, your delta goes from, remember that base 26 overall to 40. So your number needed to treat goes from 4 down to about 2.5. So again, if you're, and that's where we're segueing a little bit into diagnosis here. If you pick your patients properly and you evaluate them properly, then intervene with your anti-TNF therapy, I do think you can have these powerful differences and then actually make an attempt at altering the natural history. So again, I'm throwing up this slide to remind you about those factors that you should be thinking about in your patients, and the ones that meet multiple of these factors should probably be treated more aggressively than the patients who maybe only meet 0 or 1 of them. I'm just throwing in, it was something that we had recently done. We're not going to get into this too much, but the other point here is that when you're using anti-TNF therapy, don't be cavalier about switching from one to another and then burn through multiple biologics in a short period of time. Ironically, when we just had infliximab as an option, we sort of shepherded it and we were good stewards, and we would, before we would give up on infliximab, we would double the dose, we would add an immunomodulator, we would pre-medicate with steroids, we would do all these things to prevent loss of response. And then we got cavalier when these multiple biologics came out. And then I see patients, they've only been diagnosed for 2 years and they've already been on all 3 anti-TNFs, and nobody has sort of walked them through and optimized each drug before they gave up and switched to a different one. So before you give up on the anti-TNF, you should be thinking about increasing the dose. If you can check a level, you should be checking the level and then making changes based on that, those sorts of things, and don't give up too early on anti-TNFs. The point of this was that we found that in a retrospective study that checking infliximab HACA levels actually helped us make a more rational or informed decision about what to do next. And you can see that, for example, patients with low levels, if we bumped up their infliximab, they had a high chance of responding, whereas if we switched to an anti-TNF too early, maybe not as high a chance of responding to that. And this is a different study I did using a database that recognized that with all these anti-TNFs, there's just an inherent need for dose escalation in some patients. I'm going to skip that in the interest of time. This is another important slide, and the point of this slide is that there's a total lack of correlation between symptoms, which is what the CDEI is made out of, and endoscopic inflammation. So this was an old study looking at prednisolone. It was a French study, and you can see CDEI is on the y-axis, and the CDEIS, which is an endoscopic score, is on the x-axis. And there's absolutely no correlation between CDEI score and CDEIS. And CDEI, 80% of it is based on number of stools per day, abdominal pain, and overall sense of well-being. So you cannot make treatment decisions in Crohn's patients based on their symptoms, because their symptoms are not sufficiently sensitive or specific enough to make a treatment decision. You cannot do this. And I know this is not politically correct in these days of cost containment, but unfortunately IBD patients need lots of tests to understand what's going on. This is another way of looking at it. This was a cross-sectional study we did a few years ago, and patients who were coming through the clinic, going through an evaluation, they were getting IL-6, serum IL-6 checked, fecal calprotectin, fecal lactoferrin, their CDEI score, again, symptom, and then a colonoscopy, and we were calculating a modification of the CDEIS called the SES-CD. And what the red ones are significant correlations. And you could see that the theme here is that the one thing that correlated the least with everything else was the CDEI. And so you cannot make treatment decisions based on symptoms alone. And so that's the big paradigm shift now, is that in the old paradigm, we would look at symptoms alone to make a treatment decision. In the new paradigm, you have to look at some of these other markers, either CRP, endoscopy, radiography, and you should be trying to achieve either mucosal healing or radiographic healing. So when you make a change, you also have to follow that up with some type of a test down the road to see that you've in fact made that change. And that's the only way we'll be able to alter the natural history.
I totally agree with you for patients who are symptomatic, but in an asymptomatic patient, it's really hard to make a well person better. So if someone's asymptomatic and yet has some endoscopic disease, you're still aggressive.
I think it's a goal that we want to strive towards, but I take your point that in a patient who's feeling extremely well, their CRP is normal, they have superficial erosions on their endoscopy, I'm not going to probably ratchet up therapy on that patient. But I look at the whole picture and I look at, okay, what's their age? What's their risk of getting an infection if I immunosuppress them too much? Do they have other comorbidities? And I try to make that informed decision. But it's also worrisome when you have patients who are feeling well and then you get a CT enterography and they've got phlegmonous changes with proximal dilatation, and then, in those cases, then I do sometimes ratchet up therapy. And it's a difficult decision to make. And we need more data and we need better studies to understand this better. So the point here is that symptoms alone aren't going to get us there because all these other things could be going on. Celiac disease, bacterial overgrowth, bile salt diarrhea, irritable bowel syndrome. If they're on 5-ASA, are they having a hypersensitivity colitis, borderline short bowel syndrome? I think that lactose and fructose intolerance are actually underdiagnosed in IBD patients. So sometimes breath testing can help you out of the way. There's not much written on bacterial overgrowth, but my own personal bias is that it's rampant in Crohn's patients. There's not much written. This is a German study. They took consecutive patients and tested them for bacterial overgrowth with hydrogen glucose breath test, and 25% were positive. And again, part of the problem with bacterial overgrowth is how do you measure it? At Mayo, we do these aspirates and we send them for quantitative culture. How accurate is that? Well, you guys know more about bacterial overgrowth. You have one of the experts here about this, but it's a huge problem, I think, in IBD patients. And I actually use a lot of empiric antibiotics in patients, especially if they have a lot of gassiness or bloating. Anytime I hear the word bloat, that buys them metronidazole or rifaximin, sometimes ciprofloxacin. So I liberally use antibiotics in these patients. And I'm going to talk a few words about CT enterography. Again, you're familiar with it here. Your center has been active in this area. But you're basically combining the good aspects of CT scanning and the good aspects of barium radiography. The patient drinks a large volume of a neutral contrast agent to distend the bowel to reduce the false positive thickening of the bowel or hyperenhancement. And then you give intravenous contrast, and then you scan them in the venous phase, thin slices on a spiral CT. It does involve some radiation exposure, but that's decreasing. And this is sort of, the standard CT, you give a positive contrast so you know that they're bowel loops, but then you can't evaluate the difference in contrast between the inflamed bowel wall and the lumen, whereas with the CT enterography, the neutral contrast highlights the difference between the mucosal hyperenhancement and the lumen itself. And so you get pictures like this where you actually see what we call stratification. So you can sometimes see the three different layers of the bowel, the mucosal layer, the submucosal layer, and the serosal layer. Again, this is a little bit grainy because it's been magnified. The other thing that CT allows you to see is penetrating disease. In both prospective and retrospective studies that have been done here, but also at Mayo, we found that 20% of patients with Crohn's disease have penetrating disease, and that can consist of fistulas, phlegmons, abscesses. And so you don't pick that up with a small bowel follow-through. It also allows you to see extraintestinal findings, extraluminal findings, and many of these are clinically relevant. And over the years, I can't tell you how many renal cell cancers I've picked up in patients with Crohn's disease that otherwise would have been missed if I had gotten a small bowel follow-through. This is a study that was done here at the University of Michigan showing that this was a retrospective study showing that the CT enterography changed the pre versus post clinical assessment of the patient, and it also changed the impression of whether or not the patient would benefit from steroids in more than half of the patients. We did a prospective study along similar lines, and we took a group of 273 patients with either established or suspected Crohn's disease, and then we had to prospectively fill out a form before the patient went for the scan to say why we were getting the scan and what our management plan with that patient was going to be, and then our level of confidence of a number of findings. And then we had to complete that form again after the patient had undergone the CT scan. And so getting a CT enterography resulted in a change in management plan in roughly half of the patients. And it also significantly changed the level of confidence of findings in about 80% of patients. And meaning a significant change in level of confidence was a 1 through 5 Likert scale, and you had to move at least 2 points on the Likert scale. So it was really adding a lot of information that we wouldn't have otherwise gotten. Now what we're doing is, this was an example retrospectively of where you could use enterography, and as soon as I say serial CT enterography, usually I have to duck because there's some person out there who thinks I'm trying to kill patients with radiation. But this was an example of cases where CTE had been used to monitor patients that were on anti-TNF therapy. And this showed how, as an example here, one patient with phlegmonous changes on the left, and then in a scan a year later, those phlegmonous changes had resolved. And this is another example, lots of bowel wall thickening and hyperenhancement on the left, and then a year and a half later, that had largely resolved. And then this is another example, bowel wall thickening, hyperenhancement on the left, and resolution in the follow-up scan. When we looked at this retrospectively in 63 patients, We defined complete response as all lesions improving, partial response as some lesions improving, and no response with worsening. The median interval between the first and second CT scan was about a year, and these are the results. Again, these are all patients receiving infliximab before and after. You could see complete radiographic response in 50% of lesions and 44% of patients, unchanged in 10 to 20%, and no change or worsening in roughly 40%. And then if you were looking at the agreement between symptoms, endoscopic improvement in C-reactive protein with the CT enterography, it was only fair to poor, which some people look at that and say that's bad. I think that's actually good. That's telling us that the CT enterography was actually providing information that we otherwise weren't getting from our routine clinical assessment. Now we can get into the whole issue about radiation exposure. That's a huge issue in Crohn's. We all know about this. This was looking at Olmsted County data. The median total effective dose was 26 millisieverts over about a 10-year period. So 26 divided by 10 is 2.6 millisieverts. That was the median, but the upper quartile range was huge. This is a problem. You know, this is probably the patient who had that 29 resections right there. That's a problem at that level if that's what your sort of annual effective dose is going to be. You could spend a whole hour talking about the controversy of whether or not radiation results in an increased risk of cancer in terms of medical radiation. All I can tell you is that it's a controversial point. Nothing has been proven at doses under 75 millisieverts cumulative dose. So if we get low-dose CT involved, I don't think it's going to be a major issue. We're increasingly doing more and more low-dose CTEs. We just did a cost-effectiveness analysis. We made some assumptions using the Brenner assumptions about cancer risk with radiation and compared the cost of MR enterography, which is twice as high as CT enterography, and we found that it's basically cost-effective to use MR in patients under the age of 35 years. But after that, it becomes not clear, and if you can reduce your effective dose on CT, then CT enterography is always cost-effective. Again, there are a lot of assumptions in these models. You can tear every model apart based on how you tweak the assumptions, but this gives us a general rule. What we do in our experience is, and I try to tell all the fellows this, is if your age is under 35, get an MRE. If you're over 35, it's probably okay to get a CTE. I'll just show a little bit of data on CT versus MR. This was a nice study from the Barcelona group outlining their experience with MR enterography, a nice correlation with the deep ulcers on endoscopy. You look for the same findings: enhancement, wall thickness, comb sign. When we compared the two in 33 patients, we found pretty good inter-observer agreement. You can see that the specificity with MR actually was a little bit lower, and the inter-observer agreement was a little bit lower. And if you get a radiologist in a dark room and promise that you won't tell anybody, they'll tell you it's easier to read a CT enterography than an MR enterography. There's no doubt about it. And so I still am convinced that CTE is better than MRE. I know that's engendering a lot of controversy, but I do believe it's true. The Barcelona group has done some nice work correlating MRE findings to the CDEIS and shows that it correlates well, and they've calculated this new inflammatory index called the Maria, which is a sort of a numerical radiographic score of the inflammatory component of Crohn's disease, and it involves wall thickness, the relative contrast enhancement, the amount of edema, and the number of ulcers. And you can get this nice quantitative score. Our radiologists at Mayo actually have developed a computer program so we can get a real-time calculation of the Maria at the time of MRE, so we're going to be playing around with that in the very near future. and I'll just skip this last part, but people are now looking at using enterography in combination with colonoscopy to develop a structural damage score based on strictures, fistulas, resections, and then you could actually calculate not just the symptoms, but the structural damage, and that will reflect the fact that Crohn's disease is a progressive, destructive illness. And similar to RA, where there's a sort of a divergence between symptoms and disability over time due to structural damage, we can start studying that aspect of Crohn's disease as well. So, should we alter the natural history? Yes. Can we alter the natural history? Probably, but we'll have to be more aggressive and earlier in the course. Think about these risk factors: small bowel disease, early need for steroids, early fistulas, optimize therapy before giving up. The symptoms correlate poorly with endoscopy and biomarkers. There's this chronic progressive nature of the disease. Anti-TNF therapy may get us there where we can alter the natural history, but we need longer data. Enterography, I think, can give us a lot of information about bowel wall remodeling and also help us monitor patients after we make big changes in their therapy. And I think you'll see more use of evolution to some of these structural endpoints. And I'll stop there for questions. Thank you.
One of the things that people argue about is the gain from enterography compared to endoscopy. How much of it is seeing deeper in the wall, and how much of it is being able to see the entire small bowel areas that would just be missed?
I think it's both. So the question is enterography beneficial because it's giving us more information about the extent of involvement in the small bowel, or because we're seeing deeper into the wall? And I think it really is a combination of both. We have a paper that's 99% the way approved by CGH, actually showing that a significant portion of patients with ileal disease will have actually distal TI skipping. So you go in, you intubate the ileum, it looks normal. Enterography, there are two groups. There's one group where the whole ileum is lighting up, so they have intramural disease that's not being reflected in the mucosal layer. And then there's another group where they have true TI skipping, where they have the ileum's involved, but the very distal-most ileum is skipped, free of involvement. So we're diluting ourselves. And I think it's amazing when I go out and talk, and it's mostly private practitioners. I think people are deluding themselves. They think it's like a turf battle, that I'm actually saying that enterography is a good test. They think that somehow we're like the radiologists are getting one over on us, and that's not the case. They're complementary tests. They're measuring different things, and I think it's in every patient that comes in. It's a brand new patient to me. And they haven't had an enterography recently, and it's not a high-quality study. They need an enterography to fully understand the extent of their Crohn's disease. So you need that enterography in combination with the colonoscopy to really assess the patient.
Great talk, thanks. Question for you. You showed that 2/3 of the patients overall with Crohn's disease develop transmural disease or require surgery. I think that's what you showed, correct?
Right.
And then you showed the risk factors. But from a practical standpoint in the clinic, what can we tell our patients that have ileal disease about their risk of developing stenotic disease or requiring surgery? In other words, it's got to be higher than that 2/3 number because those patients are at greater risk. Similarly, I want to flip that around and say, what about colitis? What is the risk in patients with colitis? Because I just think it would be helpful as you're talking to patients to have those numbers in mind.
Yeah, so the risks in ileal disease go up considerably, and I don't have a great number right off the top of my head to give you, but it's certainly higher than the 60%, and I'd say it's more that 80% number or even higher. Whereas in colonic disease, that the risk goes down considerably. The part of the problem with colonic disease is that the stakes are higher. As Bill Sanborn once famously said at one of our grand rounds, he says, "I don't know about you, but my anus is worth about $2 million." So the point is that that's the most valuable real estate in our GI tract. And I think that part of the problem is that some of those colonic patients aren't getting resections because the stakes are higher, because they're going to end up with ostomies. But having said that, I think, the risk of a resection with a colonic disease is, you're getting down to more like 20 or 30% as opposed to that 60%. But we haven't broken out the data to look at it that way.
Because,
Yeah.
that's a huge piece of data.
Yeah.
If the risk
You're right.
of colonic disease is only like in the 20% range, that's
Yeah.
huge.
Yeah, that's an excellent point. We'll have to look at that.
Great talk, thank you. And
Thanks.
I just want to re-stress the point that you actually made about CTE versus MRE. It really depends on your radiology group and the experience of that radiology group. In general, if you take most radiologists in a room, a dark room, and tell them what you want, they'll say CTE. But with certain groups, especially the big medical centers where they do a lot of MRs, which is more technically demanding, but they have more experience in it, and I've seen much, much more, and they feel more comfortable actually with MR. And I think the choice comes in this what are you looking for? CTE can give you a great morphology, a cross-sectional anatomy. MRE can give you information on top of that.
Right.
So there is more advantages in MRE, theoretical advantages so far, and definitely under study. And this is what should direct your choice of what study to pick. And of course now with the low dose, we're now down to 1 millisieverts for CTEs. You can get the same information you're getting. So you're going to be able to do more radiographies in the course of the disease than you're going to do now. But again, what type of information are you looking for? Simple abscess, and that's the only question you have. A low dose CTE, which is twice the dose of PUD, you will get that answer. You're looking at more information about erosion healing, what's happening in the wall, diffusion, applying other methods, then MRE may be your choice.
Yeah, and I think the other point, it's well taken. The other point is that patient, you get the CTE because it takes 30 seconds, and you get the narrowed loop of Bowel. Was that peristalsis, or is that a fixed narrowing? And then, of course, with MRE, you have multiple series, so you can go through and, oh, that was just spasm, don't worry about it.
You get 10 bucks of the same bowel segment versus, literally
Yeah.
one shot at a time. The other thing is, we see perianal, just on our straightforward MREs, perianal disease, a very high percentage of our Crohn patients, abscesses are just completely unexpected.
Yes.
Complex fistula, facts that you're never going to see at CT because of the, just the inherent contrast resolution of CT isn't there. And then just to go back to like diffusion weighted imaging and some of these literally molecular imaging using MR, that's something CT is never going to be able to do. That, I think particularly using diffusion weighted imaging, we're finding segments of bowel that are abnormal that would have never been picked up at CT and probably wouldn't have been picked up at conventional MRE,
Yeah.
except that, you're strikingly abnormal diffusion, then you go back and maybe there is some real subtle enhancement.
Yeah.
Direct endoscopist, they go in a biopsy, the right colon in that location, and they find the colitis.
No, it's all good points, and I think it's sort of, you're right, institutional expertise. And part of it, I think, is our own simple biases, because as gastroenterologists, we can read CTEs, and we can't read MREs. Right now, I have it figured out now. I know which 2 series to go to on the MRE out of the 10 to look at, but it's still a problem for us.
We're getting there. So thank you all for coming. I want to point out 2 things. CT here is a lot less radiation than CT elsewhere, and I think that's important to patients. And also, Jordi Ramola, who developed the Maria score at Barcelona, is visiting us for the next year. So say hi when you see him down in radiology. Everybody has to run off the clinic, so thank you all for coming.
Thanks.